Okay, welcome to another clinical snippet. In this clinical snippet, before we go ahead, we will tell you a case presentation in brief of a 55-year-old female who presented to us with gradually progressive sensory loss in the lower limbs, which ascended up since 8 to 9 months, followed by weakness also associated in the both lower limbs since 8 to 9 months. And on leading questions, she also agreed that she used to have ataxia, that is frequent falls, especially in the evening hours or whenever she closed eyes. So, in brief, when we went ahead with the clinical examination, there was a spastic paraparesis. The increased tone was there in the both lower limbs, and plantars were bilateral extensor. And what interesting, another clinical finding we got was the knee jerk was slightly brisk, the ankle jerk was absent, and there was an extensor plantar. When we further examined the patient, apart from these findings, there was a positive Romberg sign. Position and vibration sense were also lost in the lower limbs.
हाथ हाथ फैलाओ, हाथ फैलाओ। हाँ, आंखें बंद करो, आंखें बंद करो, आंखें बंद करो, बंद करो।
So let us first see what are the conditions or the differential diagnosis of this constellation of clinical findings. Absent ankle jerk with an extensor plantar response. Okay. So the first possibility when we talk with this clinical finding will be vitamin B12 deficiency. So as we know, vitamin B12 deficiency usually occurs in true vegans, persons who have gastrectomized or have or had a gastric surgery with Billroth or Billroth 1 or 2 with a blind loop. Intrinsic factor antibodies and antiparietal cell antibodies usually presenting as pernicious anemia. Other conditions, as we know, that because the vitamin B12 is absorbed in the terminal ileum, so any ileal disease like Crohn's disease, ileocecal tuberculosis, malabsorption syndromes, drugs like methotrexate, which usually cause folate deficiency associated with vitamin B12 deficiency. So with these common conditions on a worm, that is Diphyllobothrium latum infection, so whatever, if the person is having a B12 deficiency over a prolonged period of time, what B12 deficiency will cause in neurology is peripheral neuropathy. Peripheral neuropathy. So usually these patients will first present with the symptoms of peripheral neuropathy, burning, dysesthesias, paresthesias, they gradually ascend from the lower limbs, go up to the knee joint, then they have the tingling sensation and paresthesia sensations here. These are painful peripheral neuropathies. And on examination, we usually get all the absence of touch, pain, temperature. So the story starts with the peripheral neuropathy picture. So the predominant target here is peripheral nerves. After the peripheral nerve involvement, vitamin B12's also deficiency attacks the spinal cord. And in the spinal cord, the vitamin B12 deficiency will cause degeneration of two tracts. One is a dorsal column, second is the pyramidal tract, the corticospinal tract, the lateral corticospinal tract and ventral corticospinal tract. So these are the two areas which will be degenerated gradually. in vitamin B12 deficiency. So when the spinal cord is affected with the presentation of corticospinal tract and dorsal column, first when we speak of corticospinal tract, the person will develop paraparesis. Like in our case, there was a gradual progressive paraparesis with upper motor neuron signs. The knee jerk was brisk and the plantars were extensor. But because already peripheral neuropathy has been set in, you will also get signs of lower motor neuron. So the overwhelming clinical presentation of upper motor neuron fails because there is also lower motor neuron already involved as peripheral neuropathy. So ankle jerk was absent. So here is a scenario, we are getting ankle jerk absent with a positive plantar extensor. Now when the dorsal columns are also involved along with the spinal cord at the corticospinal tract, the associated clinical features will be sensory ataxia. Sensory ataxia. Loss of position and vibration sense, dorsal column gone. Along with this, there will be sensory ataxia, so that the person tends to fall when the eyes are closed, especially in the evening hours when there is dim light. The problem starts and the patient sways and falls. And the positive test we do in neurology is Romberg's test. Romberg's test, which was also positive in our case, as you have seen in the video. Rombergism was present. It is known as positive Rombergism. So this Romberg sign demonstrated sensory ataxia, and in our patient there was a upper motor neuron sign in form of plantar extensor and a brisk knee, and the ankles were absent because of a peripheral neuropathy. So this is the first common thing one should think about in case of these findings. The first possibility will be a vitamin B12 deficiency. In our case, vitamin B12 was overwhelmingly low, and in the MRI there was hyperintensity in the cervical cord, long segment hyperintensity. That now the patient is on vitamin B12 therapy, but unfortunately the recovery will be marginalized or hampered, because if it had been only peripheral neuropathy, these patients, they respond to vitamin B12 therapy. But as the disease progresses and if spinal cord is involved with overwhelming sign of cord, paraparesis and sensory ataxia, positive Rombergisms, absent position and vibration sense, then the response to therapy little bit is marginalized. So this is the first thing I will consider in a differential diagnosis of absent ankle and extensor plantar. When we come to treatment, remember one thing, this is a little bit out of the scope of this clinical snippet, but we should remember that sometimes if you feel that it is a folate deficiency also, and sometimes you feed these patients with overwhelming folic acid, remember the neurological deficiency or the neurological deficit will deteriorate catastrophically. You should always supplement vitamin B12 before supplementing folate. Isolated folate therapy will be contraindicated. Evidence have suggested that folate therapy itself, folate deficiency can cause peripheral neuropathy, but extensive evidence is not yet established as far as whether folate also causes or degenerates the spinal cord long tracts. Yet to be debated, not established firmly. But yes, unfortunately somebody gives folate, what happens is neurological condition deteriorates. For that, just out of scope, but it is important, we should know what is folate trap hypothesis. What is happening in the vitamin B12 folate reaction? As you know, the folate is absorbed, is taken in form of polyglutamates. dietary folates are in the form of polyglutamates. When it is absorbed in the jejunum, in upper intestine, it is absorbed in the form of monoglutamates. Once it is absorbed, it is converted into methyl tetrahydrofolate. Then methyl tetrahydrofolate is converted to tetrahydrofolate. Here is the most interesting or the rate limiting step here. When the methyl tetrahydrofolate is converted to tetrahydrofolate, this methyl group is helping here to convert homocysteine to methionine. Homocysteine to methionine. So this methionine is a very important substance that increases or preserves myelin. Homocysteine attacks myelin. Methionine preserves myelin. In this reaction, for the conversion of the homocysteine to methionine along with this methyl group, vitamin B12 is necessary. So after this tetrahydrofolate, there is formation of 5,10 methylene tetrahydrofolate, also known as folinic acid, then dihydrofolate, then uridine monophosphate, thymidine monophosphate, then the formation of DNA. This is the way the folate is absorbed and the reaction of folate with vitamin B12. So in this situation, when you are giving the patient only folic acid, the reaction is going to stop here because you are not supplementing vitamin B12 and patient is already vitamin B12 deficient. So this step is not at all happening here. And the folate gets trapped. The reaction is not going forward. Folate is trapped here because for the conversion of this vitamin B12 already deficient, you are not supplementing vitamin B12. Homocysteine is increasing along with all cardiovascular and endothelial injury, strokes, premature strokes, coronary artery disease, vasculitis, all these are happening. Plus myelination is getting hampered and there is a demyelination, degeneration of the spinal cord. Never give only folate, you always give vitamin B12. So this is what will happen. So SSCD, ankle absent, plantar extension. Another condition that resembles SSCD is deficiency of another nutrient, which is copper. So copper myelopathy. So in copper myelopathy also, there is a subacute combined degeneration of the spinal cord like picture. And if at all the patient is having a malabsorption of any other nutrient that can cause peripheral neuropathy, you may get a sign of sensory ataxia, extensor plantar and an absent ankle. So in this scenario, I have to also go for a serum copper level, ceruloplasmin. Now coming to another condition, differential diagnosis, that is tabes dorsalis. Nowadays, is it obsolete? Do we get cases of tabes dorsalis? Usually no, because tabes dorsalis is a sequelae or a neurological manifestation of syphilis. And after the advent of penicillin, syphilis is not nowadays found. But nowadays we may get cases of syphilis when other immunologically immunosuppressed diseases like HIV/AIDS or any immunosuppressed condition may bring out isolated scattered cases of TBs also. We should keep in mind, as far as answering the question of absent ankle extensor plantar tabes dorsalis, which is known as a neurosyphilis, usually the disease starts here and tabes dorsalis develops after 15 to 20 years. So after 15 to 20 years of a primary syphilitic attack, tabes dorsalis develops. So by the time we get the clinical picture of tabes dorsalis, which we are going to see now, the primary syphilitic clinical conditions are burnt out. We may not see any of these. We will only get the neurological examination, think of tabes, and we go ahead. Another interesting thing is that whether really syphilis causes tabes dorsalis. In earlier days, in examination or in research, actually spirochete, Treponema pallidum, was never demonstrated in dorsal roots or dorsal column, because this disease attacks the dorsal roots and dorsal column preferentially. They have never demonstrated spirochetes, but after the advent of newer investigations, Treponema pallidum hemagglutination test, Treponema pallidum FTA-ABS test, fluorescent treponemal antibody, all these antibody tests was positive in cases of tabes dorsalis. So this is another situation where you get an extensor plantar with absent ankle. Now, why this? The primary target is the dorsal column. The disease also targets corticospinal tracts. The disease also targets peripheral nerve, dorsal column, dorsal roots, peripheral nerves, corticospinal tract. So, usually the disease starts with sensory ataxia, gradually progressive weakness, lower limbs, predominant sensory ataxia, positive Romberg's test. Usually the patient starts falling in night time. When you examine, there is position and vibration sense lost. And when the peripheral neuropathy starts, along with the peripheral nerves, the dorsal roots are very much excited before degeneration. So while degeneration of the dorsal roots and peripheral nerves occur, there is overwhelming positive phenomena. What do you mean by positive phenomena is the tingling, the sensory system is extremely painful. The patient's symptom will be painful, extremely lanciating, painful peripheral neuropathy. This lanciating pain can occur anywhere in the body, limbs, lanciating electric shock like pain in the limbs, upper limb plus lower limbs, face, genitals, abdomen. Okay, so the clinical presentation will predominate with lanciating pains, and sometimes this lanciating pains, when the patient presents with this lanciating pain, it is known as tabetic crisis. Sometimes it appears that this painful phenomena, is it occurring in the abdomen, stomach? So the patient usually sometimes land up in the surgical emergency as an acute abdomen, but later on it is discovered that nothing surgical is there. It is a tabetic crisis pain. So now there will be sensory phenomena, sensory ataxia, lanciating pains, as you know as tabetic crisis. Then gradually the corticospinal tract will be involved. Patient will present with paraparesis, upper motor neuron type of paraparesis, spasticity. When this will happen, the name becomes paboparesis, along with corticospinal tract, and obviously then the peripheral nerves will be involved, ankles will be absent. As you know, in the reflex arc, dorsal roots also play a major role. So all the reflexes will be already lost. So there will be areflexia, there can be areflexia. As we saw, the ankle jerk will be absent, and because of corticospinal tract involvement, the plantars will be extensor. So another situation where the absent ankle with extensor plantar is, remember, tabes dorsalis. Coming to the next scenario where we get this combination is Friedreich's ataxia. What is this condition? It is an autosomal recessive condition. Usually there is a problem in the trinucleotide repeat sequence. Here this is also known as a repeat sequence disorder. There is repetition of trinucleotide GAA, guanine, adenine, adenine. So when this trinucleotide repeat goes on, and there is no mechanism to control it, so there is excess accumulation of this trinucleotide repeat, leading to degeneration of certain neurological structures. As we told, it is autosomal recessive, trinucleotide repeat, excess specifically attacking 9th chromosome, and the gene which gets affected is frataxin gene. Frataxin gene is affected, leading to Friedreich's ataxia. So presentation age usually 8 to 16 years of age. So obviously in our case we have already ruled out Friedreich's ataxia. So this is a spinocerebellar ataxia, hereditary spinocerebellar ataxia, usually occurs at 8 to 16 years of age and manifests 100% manifestation before 25 years of age. So as we are discussing this clinical scenario, we have to talk about this because you will be asked. So by the age of 25 years, these patients, young patients, will present with ataxia. As the name suggests, it's a spinocerebellar ataxia. Spinocerebellar ataxia. So the spinocerebellar tracts, which gives the conscious presentation of proprioception through this tract to the cerebellum. So this tract is damaged. So when this tract is damaged, there will be cerebellar ataxia. And this will be gradually progressive cerebellar ataxia, which will occur in months to years. Before 25 years, the patient will present. So, apart from the neurological findings, which we will go, there are other hallmark clinical findings in cases of spinocerebellar ataxia, Friedreich's ataxia. And these hallmark clinical findings are association of these conditions. What are those? It is high arched foot, hammer toe defect, and scoliosis. These are associated findings. Whenever in a neurological patient you see scoliosis, high arched foot, hammer toe defect, sometimes known as Friedreich's foot deformity. So neurological findings along with this. And also interestingly, in some family members, when you ask or when you see some family members, on clinical examination you will see this Friedreich's foot deformity or scoliosis. But fortunately, these family members have passed the age of 25 years, but they have not yet presented with the neurological findings of Friedreich's ataxia. So sometimes this clinical presentation is not presenting with the neurological signs. This may happen, which is commonly known as formifrost of Friedreich's ataxia, meaning these family members which are elderly, not presented with the spinocerebellar ataxia part or the neurological signs, but they have these deformities. This is known as formifrosty of Friedreich's ataxia. Now coming to what are the neurological findings that we will see in Friedreich's ataxia, I have already spelled out the target, that is the spinocerebellar tracts. So usually the young chaps, they first present with ataxia, which is bilaterally symmetrical, progressive, gradually progressive, that is chronic. So long-term gradual progression of ataxia over months to years. You will get dysmetria, dysarthria, all the cerebellar signs, Hill-knee test, finger nose test, dysdiadochokinesia, all will be present. Nystagmus may be present. So cerebellar signs we will get. So along with the spinocerebellar tracts, then the disease also involves peripheral nerves, corticospinal tract. Okay, so these mean the disease will progress and there will be involvement of corticospinal tract. So whenever there will be involvement in the corticospinal tract, you will get an extensor plantar. And because of peripheral nerves, sometimes also involvement of the dorsal column. So you will get areflexia. So when the disease involves the peripheral nerves and dorsal column, usually peripheral nerves, you will get areflexia. So ankles will be absent. Overwhelming upper motor neuron signs will not be present, barring an extensor plantar, which will tell that the corticospinal tract are damaged, and areflexia will be a hallmark. So absent ankle, extensor plantar, young patients, associated deformities, Friedreich's ataxia. Next, HIV. When we talk of HIV, anything in neurology, any presentation of neurology, rule out HIV. Even it's cerebral, brainstem, peripheral nerve, spinal cord, anything, HIV should be ruled out. So when HIV occurs, there can be a scenario where there will be HIV myelopathy, spastic paraparesis or quadriparesis, along with overwhelming HIV neuropathy, peripheral nerve. So this patient is presenting with features of myelopathy plus neuropathy. So plantars are extensor, ankle or other jerks can be absent. So scenario, ankle absent, plantar extensor. HIV is a must because this can be a constellation in HIV. Any tract can be damaged. Okay, so next was HIV myelopathy plus HIV neuropathy. Okay, can simultaneous coincidence of two lesions, say in an elderly patient who is having spondylotic change in the cervical region, cervical myelopathy, cervical myelopathy, spondylotic myelopathy, and this person is unfortunately having lumbosacral flexopathy or root damage due to spondylitic change in the lumbosacral cord. The roots are coming out. So here we will get an extensor plantar because of cervical myelopathy, spinal cord compression, but because of lumbosacral root involvement, there is a lower motor neuron paralysis, lower motor neuron weakness. Cervical myelopathy, upper motor neuron weakness. Extensor plantar, absent reflex in the lower limb. So two lesions can present like this. Lastly, ALS, rare scenarios. ALS, amyotrophic lateral sclerosis, which is a variant of motor neuron disease, where the corticospinal tract is damaged along with the anterior horn cells. Corticospinal tract, upper motor neuron, anterior horn cells, lower motor neuron. So various variants along with ALS, where you can see in the lower limbs there is features of lower motor neuron paralysis, that is wasting, and there is absent reflex, along with deep tendon reflexes are exaggerated, upper motor neuron part. So combination of wasted, thinned out limb where the fasciculation is also occurring, but the reflexes are exaggerated or preserved, we think of ALS. There we can have a finding in the lower limb, absent ankle because of lower motor neuron, and extensor plantar because of upper motor neuron, because anterior horn cell, and corticospinal tract. Another scenario where you can have this. Last, cauda conus, or especially conus medullaris. Lesion in the conus medullaris. So spinal cord is ending here. The roots are dangling down beyond. Each spinal segment is sending their roots to exited in their specific foramina. That is why this is an area where any damage will occur will cause a lower motor neuron paraparesis, because only roots are there. Any damage in this area will present as upper motor plus lower motor, spinal cord plus roots. Imagine a tumor here in the conus medullaris. In the tumor of conus medullaris, because spinal cord itself is involved, you will get paraparesis. Along with the spinal cord, as you see, the roots are also getting involved. It can be lower motor neuron paraparesis. So there will be thinning, atrophy, wasting of the thigh muscles, leg muscles, buttocks. But when you go for the plantar is extensor, because spinal cord, corticospinal tract. So extensor plantar with absent reflex. Absent reflex, knee can be absent, L2, L3, L4. Ankle may be absent, S1, you can see here. So with an extensor plantar. Go for certain reflexes like bulbocavernosus reflex, anal wink reflex, sacrococcygeal reflex. These reflexes will be absent. These reflexes have their root value from S3, S4, S4, S5. So these reflexes will be absent. This will be overall clinical feature, cauda conus lesion. So these are the differential diagnosis of absent ankle and extensor plantar response. Our patient had subacute combined degeneration of the spinal cord. So to summarize, whenever you are asked, we deal with a situation like a person is having preserved knee, or mainly absent ankle and extensor plantar. So what are the differential diagnosis? Subacute combined disease of spinal cord, Friedreich's ataxia, Tabes dorsalis, cauda conus. These are the first four you should answer. Copper myelopathy can set in. HIV myeloneuropathy always be thought of. And to summarize, these are the findings you will. These are the differential diagnosis of this constellation of clinical findings: absent ankle, extensor plantar.